It's the premier meeting event for healthcare professionals from across the world. The Institute for Healthcare Improvement's 23rd National Forum continues the mission of transforming healthcare. Good morning, I'm Kendra Farn for IHI TV. The energy here is phenomenal as the National Forum kicks off its 23rd year at the Marriott World Center in beautiful Orlando, Florida. The theme for this year's forum is the picture of healthcare, and it is a picture that continues to change. This week, our IHI TV cameras are following attendees as they make their way through learning labs, mini courses, and general sessions. We're here to make your forum experience informative and enjoyable. Chances are you felt the buzz circulating throughout the forum on Monday. It was for the return of Dr. Donald Berwick to the National Forum. Later in our show, Dr. Berwick will join us for an in-depth interview. I asked him how he envisions the healthcare reform.
So much of healthcare is in motion now, and it's going to settle someplace else. I've never seen a time that seems so full of change and readiness.
You can see the interview in its entirety later in the show. The National Forum is a time to leave the day-to-day and immerse yourself in a dynamic learning environment. Our Mike Olenek has a look at what's happening around the forum.
One of the very first sessions on Sunday was called the Faculty Mind Walk. The main purpose of this gathering was to gain new perspective on the relationship between patients and healthcare professionals. It was part of a collaboration with IDEO, a design firm that uses a human-centered approach to innovation.
We designed the session today to do two things. One was to get people to step out of their daily role in the healthcare system and look at the situation from the eyes of the patient a little bit, and to start thinking about the problems, the human problems, not just the physiology problems that the healthcare system is really designed to fix.
During the Mind Walk brainstorming session, not only are all ideas solicited, but then they are shared with colorful Post-it notes, many of them having to do with better patient communication. Making sure the patient's voice is heard is just part of the goal. It's also the idea of getting people involved in hospital policies before they become patients.
We worked under the direction of some world-class experts to help us apply a methodology to think through those issues and to come up with some creative ideas of our own about solving real patient problems.
I'm a patient, and I shared my experiences at the hospital, and our team was great. We talked about things. My issue was the cleanliness of going home and taking showers, and we came up with some great ideas, and I hope they use them.
Having former patients involved in the discussion is just one way to add new perspective to the picture of healthcare.
For the thousands who are in attendance at the IHI Forum, the experience is what they will take back home.
IHI so far, based on how great the speakers are, really inspiring and motivational. And in fact, we've encouraged more of our board members to come down this year than I think ever before, based on how great we thought the conference was last year.
First year here, 3 years on the board of managers where I serve hospital district, and I just wanted to come and experience and learn about quality care and what the different ideas and suggestions are and the models that are presented here at IHI.
It's a nice combination of an inspirational experience to bring back to your system, dealing with the good work other folks doing nationally and internationally, and along with getting some of the details and actual items you can bring back to help get you to another level. So I think it's a nice combination of those two things.
It's a great opportunity to network with other like-minded individuals in the health organization.
It's quite important for me to be here with all these people who are very much encouraged by doing things about patient safety and quality. And in Denmark we are working a deal with that, and I think that we have, by the organizations as well, worked a lot with patient safety during the last 10 years. So I'm very proud of being here today, and I'm so impressed of all the presentations.
Well, we view this as a really major learning opportunity. Being from the Northeast, we often benchmark against other hospitals and health systems around the country. And this is a terrific opportunity to meet them, talk with them, and learn what we can learn about healthcare in America today.
How do marshmallows and uncooked spaghetti help improve the quality of healthcare? That's coming up after the break.
5 years ago, Massachusetts General Hospital was given the opportunity to develop a program aimed at shaping a new model of care. So far, the program has exceeded expectations by significantly reducing hospitalization, emergency department visits, and mortality rates while cutting Medicare costs by 7%.
Our theory from the beginning has always been that if we are able to deliver a better and more efficient quality of care, that will flow downward towards cost savings.
Gloria Brunet has been in the program since the beginning. Now 89 years old, she is healthy and independent, but she relies heavily on her care manager, Robin Grossman, to stay that way.
Oh, I feel great. I feel very safe with the doctors and the nurse and everyone that's been assigned to me.
Better care, better outcomes, and lower costs are absolute metrics that point to the program's success. By forging stronger relationships, the care management team is helping patients take better control of their own health. You're watching IHI TV.
The Danish Safer Hospital program was launched at 5 regional hospitals in April 2010 as a combined effort of the Danish Society for Patient Safety, the Danish Regions, and Trygfonden, a Danish nonprofit.
This improvement initiative is 5 hospitals that are trying to reduce harm and reduce preventable death in a very, very, very fast improvement program, or a very ambitious improvement program.
Its primary aim is to reduce mortality by at least 15% and reduce the occurrence of harm by at least 30% at all 5 participating hospitals.
Every patient must have the confidence for us that we are trying to do our best. And we have to have some goals to be sure that we are not doing the same as we did last year, the year before, and so on.
A very warm welcome for IHI co-founder and former CMS director, Dr. Donald Berwick. Dr. Berwick has just wrapped up his term in Washington, and we are so pleased to have him with us this morning. First of all, welcome back.
Nice to be here.
You feel like you're home?
It feels great to be here, yes.
Tell me about that welcome.
Total surprise. I walked into the hotel lobby, and there are, I don't know, dozens of my former colleagues at IHI just there to greet me. It was very heartwarming.
Sort of like a surprise birthday party?
Yeah. I couldn't say anything. I would have teared up.
Tell me, let's start with a very basic but umbrella question. Where do you, after everything in your career that you've done today, where do you envision healthcare reform?
It's a bit of a horse race. The good news is everything's unfrozen. I mean, so much of healthcare is in motion now, and it's going to settle someplace else. I've never seen a time that seems so full of change and readiness, but where it goes is a bit of a guess. The anxiety in healthcare, partly because of its connection to the global economy and the economic problems in this country, the anxiety is very high. A lot is being asked of healthcare, and if it goes in a reactive mode, just cutting things out or controlling costs, which is the main issue, in unwise ways, we'll be sorry, but it could happen. What I hope for and what I think is possible, certainly it's possible in the context here, is improving our way to success, using everything that IHI stands for to help healthcare reform so it becomes sustainable and better for patients all the time. And nobody knows who's going to win yet. It's going to depend on commitment at a level that I don't think we've actually had to face before.
You just, days ago, finished up 16 months
I did.
As the head of Medicare for the government. 16 months full of praise and criticism, as would be expected. Sum up the experience for me.
Yeah, well, first let me respectfully correct. It was head of CMS, which is Medicare,
CMS,
Medicaid,
yep.
The Children's Health Insurance Program,
yep.
And now the parts of this Affordable Care Act, this amazing new law that puts insurance companies on better behavior and is going to create exchanges for other people to find insurance. So it's a big range. I loved it. It was an amazing opportunity to participate in a really significant change in American healthcare. And most of my days were spent very busy with trying to help the agency do its work, which is massive. It's 800 $800 billion of expenditure per year going out to help healthcare do its work. Implementing the new law, the Affordable Care Act, which is a massive, wonderful piece of legislation that I just think it's the most important piece of healthcare legislation in decades, and a lot to do. And then also trying to focus the agency on quality of care. What I believed it was possible for CMS to become an agent, a force for change and partnership for improvement, which was a big message there. That was all wonderful. So a lot of the noise around, criticism and questions being raised, I actually didn't have time for it. It was in the background.
Do you feel like a year and 4 months, like you said, it's a lot, it's a big job, as the administrator for CMS, was long enough? Do you wish you had longer? Do you feel like you accomplished what you wanted to?
I wish I'd had longer. I mean, I would have loved to have stayed. It was, it's a terrific place to be. I think we got some stuff done, but time will tell how much. But the other thing, sort of philosophically, is there's always a baton getting passed. Every administrator comes, takes the baton, holds it a while, and passes it on. And I felt part of that kind of stream of leadership and history there. It was a wonderful place to be, and I think that some of what got started, not just by me, but by the president and the administration and other colleagues I had there. Oh, absolutely, it's taking root and it's going to thrive.
Let's talk about the New York Times article that probably most, if not all, of the attendees here at the IHI Forum read. The headline, just so I have it right: health official takes parting shot at waste. You have been very passionate about the waste. 20 to 30%, you said, of spending, $150 to $250 billion, you estimate, could be saved. Go through the 5 reasons and ways, the things that are causing that waste.
Yeah, well, if there weren't waste, there wouldn't be opportunity. That is, if we didn't have that opportunity in healthcare, our backs would be to the wall, because then the only way to make healthcare sustainable in our country anyway would be to take things away from people, which I think a lot of people are scared of. But it's not necessary. The whole point is that if one understands process, one understands how complex systems work, one can find areas where improvement's possible for the customer, the patient, the family, the community, and costs go down. That's just normal
efficiency.
It's efficiency. It's quality. It's the nature of quality. I think one of the definitions of quality could be to make sure that activity matches need. So anything that's going on that isn't meeting a need is waste. You can remove it, and the patient, family, customer doesn't get hurt. So that's canonical. That's just part of modern thinking about quality. So in healthcare, if you look and you say, well, what is going on that isn't helping people where we're spending resources, and which those resources could be reallocated to healthcare, they could be captured and given back to other worthy endeavors. And as Tom Nolan says, it's all wages. So in the end, it has to do with how much opportunity individuals have to use their resources the way they want. So there's failures of coordination where we drop the ball, especially for chronically ill people. It literally costs hundreds of billions of dollars in complications and rework and human suffering. There's overtreatment. There's a bunch of stuff we do to people that it just can't help them. It's there because of habit or because it's supply driven, and that.
Sad.
Yeah, well, it's being done by good people with good intention, but there's a lot of that. There's failures of reliability where most dramatically reflected in patient safety issues where people get hurt, costs a ton of money, tens of thousands of dollars for every infection that occurs that could have been avoided, and they can be avoided. There's administrative complexity, where we've just added rules and procedures and requirements that don't make much sense. Follow a nurse around a day in a ward, and you'll see how much of his or her time is just getting wasted in things that don't help anybody. They need to go away, and that includes.
If we got rid of the waste, I mean, $150 billion to $250 billion is an unbelievable figure. But if we got rid of that, if we could, realistically, how close would we be to reform?
We'd be there.
We'd be there.
We'd be there. I mean, we'd have the resources then to reconfigure healthcare to meet social and community needs, including prevention, especially helping the poor, the disadvantaged. We would be terrific. There's a problem around the transitions because it's dislocating. We have 17 or 18% of the domestic economy invested in healthcare, and that can't turn on a dime. And how to reconfigure the labor market, the institutional investments, the capital structures, training. How do you move? That's the problem. But there's no question that it would basically solve the American healthcare problem without hurting anybody. In fact, making people lots and lots better off.
So that leads me to the point of this forum. So as the founder, 23 years, I mean, really, this is impressive. This is my first year here. It's incredible. What do you hope then the thousands of attendees, whether they're in an office or an ER, what do you hope they go home with?
Well, first, co-founder. I mean, IHI was birthed by a wonderful group of people, many, many people who came together to accomplish what we're here to accomplish at this meeting. It was envisioned 2 decades ago, but it still goes on. This is the heart of the solution. I mean, the people here and the organizations they represent, they hold the solution in their hands. What I realized in Washington, as wonderful as that experience was, and it was fabulous, is that government, at least federal government, it just sets the context. It sets the stage. It makes the set. But the actors, the people that have to execute, that's the people at this meeting. And nothing makes any difference at all unless they take the responsibility, which is a positive thing, take the opportunity, and then use the science, use the knowledge to change the care. And so, from the ground up, it's like we have to have social commitment. Maybe that's top down. The country needs something. All countries need it. This is international. And that's just accepting the reality of the need of social need. But then it gets carried out in the detailed work. And the people here at this meeting are the people who can change American healthcare, and that's what's so exciting about it. And they know they can. I don't know if you sense the sense of celebration.
We talked to several of the board members last night, and it's almost like it's a movement. It's really a community and a movement, and you're just drawn in, and you almost feel, I got the feeling that there was almost a sense of irresponsibility if you weren't part of it.
Yeah, it's onerous. I mean, the amount of change that we're now looking at is very big, even in the vanguard, even the people here. Yeah. But the opportunity is amazing, and the risks of not acting, they're really big. So I'm glad to be here.
Last question. Whether it's with the federal government, whether it's with IHI, you have always, for decades, maintained and been just your passion and your advocacy for safety and quality and patient-based care. So everybody wants to know, now what for Don Berwick?
I don't know. I'm going to stay committed, as I have been for 3 decades, to trying to help healthcare get better. That's really what I want to do. It's fun. It's related to my self-image as a physician. It gives me a chance to work with the most wonderful people in the world, all of the people here, and in other countries. And I'll continue to do that. The platform, I don't know yet. I mean, I'm going to, right now, a little bit of a break will be nice. It's been really intense the past 16 months, and looking forward to getting reconnected with my family and doing a little cross-country skiing. And
you're not going to go to Disney World?
Maybe that too. 2 new grandchildren, so sometime I'll take them there. And then we'll see. I have no doubt that I'll continue to find ways to be working with the very people who are here. This is my home team.
Good. Thank you. It was a pleasure.
Thank you.
As we've been making our way around the National Forum, we came upon a unique mini-course. IHI TV's Michael Lennick joins us with the story.
I'm here to find out what marshmallows have to do with healthcare improvement. Jason Leach joins me now. Tell me a little bit about the activity we see going on.
So it seems strange. They have 4 things at the tables. They have a marshmallow, they have 20 sticks of dried spaghetti, they have a thread, and they have tape. So what they have to do is in 18 minutes they have to build the tallest freestanding structure that they can. Now, so the learning, and I have to say this quietly so they don't know, is that what will happen almost universally is they will think and think and think and overthink, and they'll build and build and build, and then right at the end they'll put the marshmallow on the top and everything will collapse. And about 2 groups in the whole room of 100 people will end up with a structure the way it was designed. And then we show them a video clip of some people who have done it on big scales, and it turns out that nursery kids, kindergarten kids, are better at this exercise than CEOs. They're better at it than doctors and nurses because kids don't care about failure. So kids just build and it breaks, build and it breaks, build and it breaks, and they just keep learning and learning and learning and learning. And we've forgotten how to do that. We think there's one solution. So we seek that one solution round our table. We plan and we plan and we plan. And then right at the end, we put the marshmallow on the top and the whole thing fails. So that's the key learning which we're trying to get them to do. So it's about testing change.
Okay, so this is actually symbolic of an idea that they can take with them and apply back in the real world of healthcare?
So we're in the middle of a day when we're trying to teach them about execution. So we started the day with really challenging their perception of what a healthcare system is. So trying to make them think right outside their normal parameters. Now in the afternoon, we're moving to how do you execute that change? How do you really make that change? Because the temptation in all of us, particularly leaders, is to sit around, work out what the answer is, and then just tell everybody that's how we're going to do it. We'll send everybody a letter and say, that's the execution. Just get on with it. We've decided. The reality is much messier than that, of course, and it requires people to test those changes in their context. We have people in this room who are from Denmark, who are from the US, who are from the UK, who are from Ghana, and each of them will end up in a completely different place because their contexts are so completely different. But the key is that testing and that ability to make changes at their front line, whatever their context happens to be.
Okay, and does the winning table get to keep the marshmallows?
The winning table gets to eat their marshmallows. One of the rules is they can't eat the marshmallow during the exercise, otherwise the marshmallow gets smaller and the exercise gets easier.
Oh, okay.
So, but maybe we should have had a prize. I maybe should have thought of that. Maybe you need a chocolate bar to give the team that wins.
We'll save that for next time. Thank you very much, Jason, for joining us on IHI TV. And yeah, apparently for the record, they will not be making s'mores later tonight. Kendra, back to you.
The IHI 23rd Annual National Forum officially kicks off this morning with the keynote address from IHI President Maureen Bisignano. Here's a look at what else is on tap for today.
When Mission Health System began its quality improvement journey, they decided to start inside the Medical Surgical Intensive Care Unit at their flagship hospital in Asheville, North Carolina.
So our first initiative was spontaneous awakening trials, also known as sedation holidays. The landmark article came out in 2000 in New England Journal, proving and showing, really without much doubt, that daily spontaneous awakening trials improve patient outcomes, gets them off the ventilator faster.
Every week, the medical surgical ICU team gathers to get a sense of how they're really doing. This is one way data is fed back to the caregivers and shared transparently.
I'm most proud of how our team has come together and learned and increased its capacity to learn again. Seeing skeptics and nervous folks at the beginning, to see the pride and the smile on their faces, not because they're proud of themselves, but because they see their patients doing better right in front of their eyes.
Learn more about Mission Hospital's quality improvement journey by visiting missionhospitals.org/mission values.
You're watching IHI TV.
North Shore Medical Center, based in Salem, Massachusetts, a member of Partners Healthcare System, is among the top 5 busiest emergency departments in the state, with more than 90,000 visits each year. As part of the hospital's Culture of Excellence initiative, the medical center has made a perfect emergency care experience priority 1.
They've come to us looking for care. We have an obligation to provide perfect care for them at that point in time, and that's what we're going to do as we treat these patients.
The program, which is officially known as iCare, for Integrated Care and Rapid Evaluation, is still in its pilot stage, but already patients are feeling the benefits of a new team-based approach.
It's amazing how nice and friendly the people are, how smoothly it ran. They saw me, they moved me right through.
We always want to make it better. We always want to make that patient experience better. We always want to know that at the end of the day, when we walk out that door, that we did the best job that we could.
To have somebody who comes in with a relatively simple complaint that should only take 15 or 20 minutes to address, and to be able to do it in that amount of time and see them leave with a smile on their face and a sincere thank you is tremendously fulfilling.
Welcome back. IHI TV crews are here in Orlando talking to attendees, faculty members, and other key players at the forum. Here's Mike Olenek with a spotlight on one hot topic.
One of Sunday afternoon's learning labs was about political pressure and barriers to safe care. Inside, it was a lively discussion at times, which included patient representatives.
We're talking both about hospital politics as well as broader politics, government politics, the pressures that hospitals come under because of the prevailing health system, because of the culture. As it turns out, there's a lot of culture of blame about when something goes wrong. But there's also some structural issues about the way that the health system is set up to be able to support hospitals who are trying to provide better care.
What is it about this topic that makes things kind of emotional?
I think it's the thing that really sparks people off is when you start to talk about the role of patients in some of the deepest problems that we have around safety. So if something goes wrong, to what extent are we prepared to bring patients in to help us solve the problem? And the discussion that we were having in there was about do we bring in the individual patient who was harmed or their family, or do we bring in a patient representative to be at the table, or some form of both, depending on what the situation is. And it's interesting because our instinct as physicians is to be really careful about not letting patients in. Some of that has to do with litigation, but it also has to do with a culture of blame. If something goes wrong, someone's going to have to pay for it. And that's the culture. And what we're trying to talk about here is how can we support a system so that if something goes wrong, we make sure it never happens again. And that person so there are two victims. There's the person who's harmed and the person who did the harm, who are both traumatized by what happened and both need to be supported.
This learning lab was one of the many discussions here at the National Forum about the culture of healthcare. For IHI TV, I'm Michael Lennick.
And coming up, a medical student from Ohio talks about his other school, the IHI Open School. We'll have that when we come back.
The Palo Alto Medical Foundation, part of the Sutter Health Network, cares for 1 million patients a year on the peninsula, from San Francisco to San Jose, into the East Bay, and west to Santa Cruz, California. The Variation Reduction Program is an initiative aimed at improving quality by identifying variations in patient care, as well as reducing costs.
So our clinical variation reduction program is all about improving the quality of service and care that we're providing to our patients.
Dr. Lawrence Shapiro, a pulmonologist by training, spearheaded the variation reduction effort. He understood that for change to really take root, physicians had to be a part of the process from the very beginning.
My pitch to the docs is we're doing this because we're a profession. And as a profession, we have a responsibility to our patients. We understand that there is sometimes warranted variation. What we try to do is take out that warranted variation and then get down to the core of what's unwarranted.
Learn more about the Variation Reduction Program by visiting PAMF.org.
You're watching IHI TV.
Located in Ogdensburg, New York, along the St. Lawrence River, Claxton Hepburn Medical Center is a 130-bed acute care facility that serves New York's largest county based on area. It has distinguished itself as a leader in areas of patient safety and quality care. Nurse manager Jennifer Shaver and her team established new practices on important clinical bundles to reduce bloodstream-related central line infections, ventilator-associated pneumonias, and pressure ulcers.
I started by measuring our compliance in those areas, not looking at farther outcomes, but measuring the compliance and sharing them with the staff. And they talked amongst themselves about, wow, we were 100% compliant this month and doing this, this, and this.
The campus has really expanded from just the hospital itself to now with the Cancer Treatment Center, the medical office building, we have the renal center, the wound care center, clinics in the area towns around us. I think we've expanded our services to better serve our community. I mean, that is the mission of the hospital.
Learn more about Claxton Hepburn's success story by visiting claxtonhepburn.org. Let's first start with you are a medical student at Wright State University, fourth year out of a 5-year MBA program. Mm-hmm. How did you hear about the IHI Open School?
So the open school, I kind of stumbled through, one thing to another. I went to a patient safety conference in Columbus where Dr. David Nash was speaking, who's at Jefferson, and he mentioned something about the open school, the IHI. I'd never heard of it before. Kind of went and Googled it, looked it up, and this is pretty interesting. Sure, I'll sign up. And then I found out that it was kind of right around the time when there was this Student Quality Leadership Academy, which was at the IHI headquarters in Boston, in Cambridge, and I was very fortunate to be able to attend that, and it was just completely, really gave me so much direction. I can't emphasize that. A lot of people used to ask me why I was getting an MBA, and I couldn't tell them because the assumption is, oh, you want to run a hospital, you want to make a lot of money, and it wasn't exactly that. And then I went there and I realized that this is what I want to do, and IHI is the way that they know how to do it.
Can you tell me? Obviously the point is for future healthcare providers to really drive home and motivate them when it comes to safety and quality and patient-based care. Take me into your hospital that you spend a lot of time in Ohio. Give me an example of where you see it's needed.
So one of the nice things is that we rotate through several hospitals, 7 actually in Dayton, and I can say, for my part, the hospitals are, I think, excellent. Obviously, I don't have that much experience, but the hospitals are excellent. But a lot of my classmates and I, we all have little stories that you hear when we talk to each other about why did this happen? Why was this patient not given this drug and something happened? Or small things, sometimes bigger things, and I started to realize that there's it's almost like there's too much consistency of things going wrong like this, and even in these institutions which are just really, I think, spectacular in the care they deliver, there are still these systems level problems because it's so complex. It's so complex, and there's still these problems which come up that are essentially problems of quality and that result in problems with patient safety. And I think that's what really, we were all experiencing this as individuals before the IHI and the open school really started to, to have a presence in Dayton. And that's when we realized this isn't just something I experienced. This isn't just something we're experiencing in this hospital or these hospitals. It's something that's happening everywhere.
You actually are the chapter president in Dayton. Right. Tell me what, as the president, you really try to impress upon with other students who may not really have the sense of awareness that you have.
Sure. So I think I'm just gaining a sense of awareness. But one of the things that I realize is that a lot of medical schools are, not to say anything wrong with it, but haven't yet adopted a lot of quality improvement and patient safety work in their curriculum. So one of my goals as the chapter leader is in that end to actually put some of the open school curriculum into our medical school curriculum, and that I'm really happy to say is finally happening now. So all kinds of things on the administrative end. I mean, now doing the coursework and completing that and getting that certificate, that's going to be on your dean's letter now. So that's a big change also. Now, in terms of students and getting them interested in knowing what's going on, I've noticed it's interestingly difficult. When we've spoken to first-year students and told them about the Institute of Medicine report and these problems and what we're trying to fix, and you can see their eyes just widen in terror at kind of the, they don't necessarily always realize the responsibility that's going to be on their shoulders, I think. So, but you open it up to people and people realize, medical students, I think, have been extremely just energetic at realizing that there is something that they have a role, even as medical students. I think that is one of the great things about the open school, is that it gives us a role, it gives us a way to get involved right now.
The IHI Open School is free and open to all students. We hope you've enjoyed this edition of IHI TV at the Forum. Join us again tomorrow for another exciting wrap-up of the 23rd Annual National Forum.